Thank you all for being here and joining us today. I'm Noelle Sullivan. I am the Director of the Program in Global Health Studies. And before I get involved with introducing our illustrious speaker for today, I just wanted to give you a few details. One, it's to thank the Provost Hollister Lecture Fund for giving us the funds to be able to do this. This is the second to last speaker in our speaker series for this year, which I wanted to also express some gratitude to Peter Locke, who has been fundamental in organizing the speaker series, and Lauren Carr, who has been doing all of the logistics to be able to make this happen. In addition, our last talk of the speaker series is next Friday, and we have Dr. Roberto Barrios, who is coming in to talk about how his studies of natural disasters and recovery have actually translated to thinking about pandemics and looking at pandemics like COVID-19. So that's the same time next Friday, and I hope to see you there, same room. So it's a privilege to introduce our speaker today, Dr. Shailey Prasad, who is the Carlson Chair of Global Health, the Executive Director of the Center for Global Health and Social Responsibility, and the Vice Chair for Education at the Department of Family Medicine and Community Health at the University of Minnesota. He is a family and rural medicine expert, global health expert, and he has been a global champion of the importance of giving primary care to the highest quality at home and abroad, and participating in and fostering equitable global health partnerships that remain accountable to the communities where they operate, and establishing the infrastructure and programming necessary to train the next generation of providers in family medicine and rural health. I first met Dr. Prasad probably about a decade ago, where someone's like, you have to meet Dr. Prasad, I'm going to set it up. And the first thing that he said after we said hi was, how can I help you? Which is actually really the foundation of pretty much all of the work that he does, is bringing people together, figuring out how to make an actual difference on the systemic, more challenging things that are barriers to being able to have robust healthcare and robust health outcomes for the widest swath of people out there. So with no further ado, please join me in welcoming Dr. Prasad.
Thank you, Noelle. That was wonderful. It's been a great journey. The two of us had less gray hair then, 10 years ago, but we wear this gray hair with a lot of pride, so there we go. I do have a presentation. I was asked to prepare a presentation, but we don't have to go into that. It's up to you, okay? But I'm going to start with a few premises. One, there was a little bit of a buzz when they looked at the slide and said, my center's name is the Center for Global Health and Social Responsibility. I got to acknowledge that name was there before I took over as a director, so I was not responsible for it. And I was troubled by it because I was trying to find a nice acronym. Doesn't become a good acronym. But the good news is we are the only such center in the world. So if you say Global Health and Social Responsibility, my center name comes up first. Thanks, Google, right? But inherent in that is a spirit that we've all within my center come to acknowledge and recognize that our participation in health-related activities globally, and we'll talk about what that means, is a responsibility that we bear to society. And as institutes for higher education, we have a huge, important role to play in that. And I'm saying this because we are hearing criticisms across the world, particularly here in the US, criticisms about institutes for higher education and how we are not relevant to community-related activities. And a lot of that criticism is appropriate. I can tell you many of our institutions, including mine, are in a beautiful bubble. And community engaged work is a random, once in a while, look how great I am. I have decided to go to this neighborhood kind of activities. That's not what we should be doing. So that's the framework I'm going to start with, okay? Noel asked me to talk a little bit about global health and rural health. And we'll talk about that, where the two meet, and why that is important too. And some of the activities we have done in Minnesota, we're sort of very proud of some of the changes we've been able to make there. And I hope that that becomes a framework of some of our conversations, okay? Now, like in most presentation, I'm supposed to be having my objective section. And my objective is very simply to hold the tension. What I mean by that is I might say some things that are deliberately controversial, that might make you uncomfortable. And if it makes you uncomfortable, I'm going to say, yes, that's my job. What comes out on the other side of it, we can talk. I don't have any specific conflicts, except Noel has also mentioned that I'm a family doc. I have a very, very, very strong bias towards primary care. And I can talk about why that is important, not just here in the US, but around the world, and what we should be doing more on that too. All right? Ready? All right. So in preparing this talk, I was like, okay, I need to anchor the conversations around a few things. So I said, okay, let me think in all my time of working in global health, in primary care, in rural health, what are the things that have struck an important chord in me? One of that was a conversation I was having with a colleague in Uganda, at Makerere University in Uganda. This is somebody that I've worked with for many years, brilliant researcher. He's an expert in cryptococcal meningitis in HIV patients. So he does some amazing work. And the reflection both of us had was that my life is very similar to his life. He lives in Kampala, Uganda. I live in close to Minneapolis in Minnesota, the US. There is a few material differences, but majority of the times in terms of what we do, how we looked at the world, our privileges and our activities is very similar. And the life of my patients that I still practice clinical medicine, some of the poorest neighborhoods in the Twin Cities and in greater Minnesota, is very similar to what he sees in the neighborhoods of Kampala. So I'll park that around for a minute, okay? Because that inherently brings up that question, what the heck is global health, right? Is it because he's in Kampala that it's global? That's because I went on a plane trip to Kampala that it became global? So just park that for a minute, okay? Now I'll introduce that your next speaker is going to be talking about disasters. Anybody recognize this? You guys, many of you in this room are probably too young to remember this. Yeah, yes. Yeah, that is Katrina. I think we do a disservice by giving these monster storms cute names. I was a rural doc in Mississippi when Katrina hit. Before Katrina, the biggest catastrophe that had hit the Gulf Coast of Mexico, of the US was Camille, 1969. I think we should name them different. We should call them Attila the Hun or Genghis Khan or something like that, right? And it's Katrina. It's like, yeah, whatever, right? Katrina was devastating. The eye of the hurricane was 55 miles across. Just the eye, the safest part of the hurricane, by the way. My house happened to be right in the path of the eye, so we were relatively spared. But I'm not talking about Katrina as such. Katrina was a mega disaster, not from just the environmental thing, but from the response side too. There have been more than 4,000 organizations that were documented to have gone to southeast Louisiana and southern Mississippi to help in the aftermath. But what struck me was a couple of stories in local newspapers where communities told people who were coming, no, we don't need you. One community actually in east of New Orleans, in what's called St. Bernard Parish, they actually kicked out an organization. Again, park that for future discussion, okay? And the third one, I'm going to borrow from an illustrious person who wrote a beautiful op-ed a few years ago about a teenager who practiced, quote, quote, air quotes, medicine in Florida. And he billed Medicare. After a few months, they discovered that he was a fraud. He was not a physician at all. And he was appropriately put to jail. But this op-ed asks the question, if the same person had been going to another country, insert country, Kenya, Nicaragua, Tanzania, we would have said, look how great a person this is. By the way, Noel wrote this op-ed, okay? So you got to thank her for this. More to come on this topic. Let's, again, park these three anchor points for future discussion. Ready to move on further? So then the question I have for you folks is, what is global health?
Is that rhetorical?
No, I want a good audience participation. What do you think is global health? When the term global health is bandied around, what comes to mind? There are no wrong answers, by the way. Oh yeah, but not here. Thank you, Noel. I am holding the tension here. Isn't that fun? What comes to mind? It can be just blurt out words that come to mind or statements that come to mind. I'm not looking for definitions. Go ahead, please.
So, I'm not saying this is what I think it should be, but you're asking what does it make me think of?
Yes.
Think of humanitarian aid.
Aid, okay. Yes.
Whether the conditions are sanitary, like water or food, that we take, that some people in the developed countries take for granted.
Wonderful. The living circumstances around it. I love that. Okay. Yes.
Well-being of people across the world. I think of well-being mentally, physically, and holistically.
My work here is done. Okay. Wonderful. Thank you. Well-being. What else?
I would say like the policies implemented by governments or organizations to help out people.
Okay. Policies at the macro level. Okay. Other thoughts? Yes.
I think people tend to think of global health as health occurring like elsewhere
Ah.
typically instead of actually global everywhere.
It's like whatever happens out there somewhere. Right. Okay. I love that. Okay. This is good. This is good. So, a couple of weeks ago, I was walking around my neighborhood with our dog, and I met one of my neighbors who had recently moved to the neighborhood. And, oh, who are you? What's going on? And blah, blah, blah. Oh, I work in global health. Great. I want to go on a trip with you. Okay. To carry my bags? No. What exactly? Well, I've always wanted to give back. And my giving back is I want to come with you when you do your clinical stuff. And are you a clinician? No. By the way, I do no clinical work outside the US. I do no clinical work right now outside Minnesota. I am licensed to practice in 4 states in the US. Wisconsin, from where my house is, where my office is, about 35 miles away. I don't cross the border to practice medicine in Wisconsin. Because if I do, it is a crime. It's illegal. So why should I be allowed to just waltz into, again, insert country and say, look how great I am? So I don't do clinical work elsewhere. Can you do clinical work? In certain circumstances. We can talk about that if you're interested. But the understanding of what constitutes global health is partly what is out there, and almost always is equated to those poor people have nothing, so we will do something. University of Minnesota is known for its hockey, because, we have like ice for like 10 months of the year. I'm not talking about ice, but ice. And it broke my heart because an award-winning goalie of a women's hockey team was lauded in our University of Minnesota Foundation newsletter because she went to Haiti to deliver medical care. She was an undergrad, a brilliant hockey goalie with zero clinical values. I had to call them out on it. How would you like if a brilliant goalie came to your house to deliver a baby in your house? She's a brilliant goalie. She'll make sure that the puck is not dropped, or whatever the term is. Why are we allowing this? And the reason I'm bringing this up is not only are these practices unethical, illegal in majority of the circumstances, it carries a great degree of hubris. It starts with the premise that what we have as a dominant culture, we can, number one, export. I'm here to tell you that the US healthcare system is broken. I've been practicing in the US healthcare system for 30 plus years. It is not the most efficient, it's not the best. There are some things we do really well, but a majority of things we don't. So why are we demanding that we export our models in a way that is done by people who don't have qualifications, or when they do have qualifications, those qualifications are significantly geocentric. They are here in where you're allowed to do it. Why are we allowing to do it elsewhere, right? So for me, the definition of global health that has stuck a chord that's been dear to my heart is this one. And there are many definitions, and feel free to review a lot of them. And the reason I like this is it does talk about a few important things. Achieving health, improving health and achieving health equity. And yes, the premise of well-being was brought, and I think that's a very important part of this conversation. And people worldwide. There was no mention in this of the boundaries have to be in a particular way, that they have to be in a country we like, or in a country that speaks English, or in a country that is easy for us to travel to. None of that is mentioned there. So inherently, there is this premise of a universal solidarity in this, right? It is difficult, and we'll talk about why that becomes important later on. It's difficult to achieve all of this. But it's key for us to keep in mind that understanding this definition with a great sense of humility is critical. I'm a very good clinician, is what I've been getting annual reviews for. But I dare not practice in a place where I have not seen the local milieu, the local diseases. That is a critical part of this conversation. And more importantly, where I don't always understand that particular health system. So keep this in the back of your mind. Inherent in this is, I feel, an unspoken part about governance and policy. Because it is like, yes, but how? Like if you were to ask me to design healthcare for the near north neighborhood of Minneapolis, yeah, I can do that. There are some parameters, right? There's a geographic parameter. There's a sense of who lives there. But if you ask me to do it for the world, you're like, ooh, let me step back here a second. We'll have to talk about pandemic treaties. We'll have to talk about sovereignty of countries. We'll have to talk about supply chains. We'll have to talk about political economy. We have to talk about economics. It becomes more complex. And then inherent in that is a challenge of the governance. 2 years ago, I had a student ask me, what is the biggest challenge facing global health? And I'm like, there are many, but I would say climate change and health is a huge part. Now, I would say, no, it is governance. It is understanding that there are solutions that we should be doing, but we don't have consensus in how, who does this. Questions? I'm going to spend like a brief minute here because this is one of my favorite topics to talk about, because where did we come from kind of question, right? I used to talk about the eras of global health, and I'm sort of backtracking on that because we are in a very interesting inflection point, potentially of a new era in global health. Dissemination of ideas and knowledge, understanding of cultures or not understanding cultures has been going on for a long time, centuries, right? There's some fascinating stories of exchange of ideas in terms of how to practice medicine, et cetera, et cetera. Also, have you folks heard about that thing, what do you call it? COVID. You heard about it, right? COVID happened because a particular virus decided that it's bored of one species, it's going to jump to another species, right? Viruses have been doing that for a long time. Bacteria have been doing that for a long time. Bugs have been doing that for a long time. The interspecies jumping, if you will, of microbial agents have been going on for a long time. But 500 years ago, it probably took 150 to 200 years before it went around the world. Now, 4 days, 5 days? That's another very important thing for us to keep in mind, because the importance of taking care of everyone is much more critical than ever before. But the tropical medicine era is something we should talk about, because in the 19th century, there was a sense that, oh, there is some exotic places around the world. It was a spirit of adventure. It was also the spirit of high colonialism. 1851 had the International Sanitary Conference, which is considered to be the root of today's global health security agenda. And the premise of the International Sanitary Conference was keep those diseases out there in big, bad Africa. We don't want that to come to Europe. It was not a, we need to take care of everyone. Unfortunately, that tenet still exists in the global health security agenda. Monkeypox became a problem when we started seeing monkeypox in Europe. By the way, attention to COVID became a problem when we started seeing it in Italy. Not when we saw it in Korea, not when we saw it in Thailand. Only when it started affecting Italy, we were like, oh my God, how dare that virus come to our shores, right? That legacy of that tropical medicine era is still there. In fact, there is an American Society of Tropical Medicine even now. It was also a spirit of adventure. People would go to exotic places, find diseases, and name it after themselves. The British colonial army, Lieutenant General Leishman, after whom leishmaniasis is named. There was a disease in India for centuries which was called Kala Azar, the black disease. Why don't we call it Kala Azariasis? You know the story of Mount Everest, by the way? You heard about Mount Everest, right? Yes. Do you know the story of Mount Everest? Okay. A member of the Indian, I forget the organization, surveys, he was doing the surveys, needed a weekend to go to his family. And he was measuring a mountain up in the Himalayas. And he decided, I'm going to name this particular mountain after my boss, so he'll give me some time off. My boss, Mr. Everest, we named this Mount Everest. The native name for Mount Everest is Sagarmatha, the mother of all oceans. Isn't that more beautiful? Have you heard of Victoria Falls? Where the Zambezi plunges. Is one of the most beautiful waterfalls in the world. The local name for that is Museo Tunya, the smoke that thunders. I would love Museo Tunya. Why some lady who's never been there ever? Lake Victoria, right? That is still a legacy we see in health, in medicine. It is a sense that all of what we do in medicine is that conquest and naming after yourself, planting a flag and saying, this is leishmaniasis, not kala-azariasis, or just kala-azar. Why do we need an asiasis? It's important to keep in mind because a lot of the thoughts that originated then led to the formation of what happened in the 20th century. 20th century was also a time of a lot of cooperation. After the World War, we had to first fight each other, then realize, maybe we shouldn't fight each other. It was the birth of large, what are now called INGOs, WHO, UN, UNICEF, FAO, etc., etc. There was supposed to be a spirit of cooperation, a sense that we should be doing things together, what was classically referred to as multilateralism. You can ask the question, was it truly multilateral? And I would say no, because it's still policies debated and discussed by a select few, imposed on others. It was not truly multilateral, but we had structures in place. We still have those structures, WHO, UNICEF, etc., etc. This last year, I was at the World Health Assembly in Geneva, and one of the terms that I heard used quite often was that the US is committing leadership suicide. It's probably a very apt way of saying how a public policy as far as world affairs is going, right? And one of the criticisms was that the WHO was too expensive. The biennial budget of the WHO for 2 years was around $7 billion. A big amount of money, right? Little less than $7 billion. And give the example of one healthcare system that takes care of about 1/4 of the population of Minnesota. Minnesota's population is about 6 million people. 1/4 of the population of Minnesota is taken care of by one particular health system called Fairview. Their annual budget is about $7.5 billion. So you're telling me WHO is too expensive? Anybody know what Northwestern's annual budget is? It's probably about 30 billion or so, maybe. Yeah. So why are we saying that WHO is too expensive? Just an excuse to cut, right? Now, is the WHO the most efficient? Nope. We wrote an op-ed about it. WHO is not the most efficient. Granted, it needs some reform. It can be done. But for us to reject things at the macro level is a huge challenge. And that has also pushed us towards the idea of moving from health to a very reductionistic view of understanding health from a purely biomedical viewpoint. So your premise of your question about well-being is a beautiful one because we don't talk about that enough. We talk about diseases. We talk about sickness care, not wellness care. Now, I'm trained as a clinician. It's important for us to do both. But we all know that clinical care contributes to about, any guesses what percentage of the health of a community is really benefited from clinical care? About 10 to 11%. What I mean by that is the overall health of a community gets better from clinical care. The contribution of clinical care is about 10 to 11%. Where does the money go? To that. That is unfortunately the legacy of what I would say is Global Health 2.0, which is the international health part of it. The international health part of it was also the birth of single disease approaches, malaria or bust, TB or bust, HIV or bust. Some of them are quite instrumental in changing the course of the disease. How many of you have heard of PEPFAR? PEPFAR, ring a bell? Yes? Do you know the full form of it? Yes. It's George W. Signature Achievement, yes. Yep. It's the President's Emergency Program for AIDS Relief. That's the number one reason why we saw the HIV pandemic, which is ongoing, by the way, started showing a downward dip in a majority of countries that had HIV, and we know when that happens, the HIV rates around the world drops too, right? PEPFAR is very important. It's a vertical program, but we spent a whole lot of money on it. I'm not saying these vertical programs are not important. I'm saying we are spending too much money on the vertical programs without building systems. So what happens when a new disease comes? We don't like you. We are HIV people. There's so many stories, and actually Noel has written about it, where money for PEPFAR there's so much money, it was put into use for a children's playground, where taking care of diarrheal diseases was probably the most important thing in that community. But diarrheal diseases are not sexy, right? If you go to a donor and say, I want to work with chlamydia, they're like, what? But I want to work with a rare disease that 1 in 2 million people have. Yes, that sounds very important. This is the irony of what we are facing with. Most of what is needed in global health is boring. And I'm the master of boring. Unfortunately, what happens is there's an approach towards global health from this title is important. This particular disease approach is important. And we forget the overall benefit in communities. Because who would want to be known as the person who eradicated chlamydia? By the way, HIV had a lot of stigma, right? There was not much funding with HIV when the stigma was there. It's only when the stigma went down, the funding started. Cystic fibrosis. You've heard about cystic fibrosis? It's a disease that predominantly affects white people. It's a rare disease. The amount of money that goes to cystic fibrosis is more than 100 times the money that goes to sickle cell anemia. Why is that? I'll let you discover that part. So in this context, we have to keep in mind that the priorities are not always set by what the communities need. They are set by people who say, I like that shiny object. There's a slight anecdote. I want to mention this because I was in a panel with actually one of my former trainees, and I've decided that I will never sit in a panel with him ever again. His name is George Umandi Paul. He's a veterinarian. Because we were talking about global health challenges, and I'm talking about diarrheal diseases and, taking care of communities with cholera. And George starts his talk by, the last time I tagged a lion, who's going to listen to diarrheal diseases when he has a lion story? Right? So the focus in global health goes to that shiny object. And that shiny object is sometimes not determined by the community themselves, right? It's determined by somebody sitting somewhere far away. That is an important concept to keep in mind as to, are we doing the right thing from a funding viewpoint? And by the way, the funders are waking up to this. They have been asking the question, are we part of the problem? And that is something to keep in mind because we'll come to that in a minute. I used to be talking to everybody about the importance of what we should be doing more in global health. And if there's one byline, I would say it's about learning from and with each other. There should be that sense of humility that I don't know the answers, but I'm here to learn with you. I'm here to work with you, right? That should be the premise is what I would say. But we don't do a good job of that. This was written by one of our favorite writers, Shailey Abimbola. I would strongly encourage you folks to pick up The Foreign Gaze, which is a collection of essays by Shailey. I was telling Noel that I had a fanboy moment because I cooked for Shailey. He came to my house and I cooked for him. Yay, my fanboy moment, ultimate. But Shailey talks about the importance of epistemic justice because we feel sometimes that the premise of quote-unquote modern medicine, whatever that is dictated by certain norms that have been reported and repeated because it's a dominant narrative of how things have to be understood. During the 20th century, there was a massive growth of what are called mission hospitals, usually church groups, almost always the sisters, never the padres, who set up really wonderful hospitals in the US. Majority of the original hospitals in Minnesota were set by the sisters. And they did an amazing job of care delivery in communities. But, and here's a but part, right? We knew that was coming. Did that lead to a suppression of other ways of knowing? Do we really understand how to take care of community mental health? If we did, the mental health crisis we have right now in the US would have been solved. We don't. I would say the US system of taking care of mental health is one of the worst in the world, because you wait and then you slap them with a bunch of medicines and say, ha, it didn't work. And by the way, do you have insurance? It's not about wellness. It's not about community wellness. It's not about understanding diseases in a way that is different from a dominant narrative. So epistemic justice asks the question of who gets to decide what knowledge is. So we wrote a paper in this January. It was published in The Lancet, and I was thrilled to be part of it because we reviewed all the primary care literature around the world to see where the literature originated. Any guesses? The US, UK, and a couple of European countries. That's it. Does that mean that people in that other countries are all dumb? We are not listening to those voices because we come with our narrative that this is the way. We have to be humble to say, this is one way. I'm not here to reject all that modern medicine has achieved. I'm not saying that what we have done in developing clinical care algorithms, mental health frameworks, psychopharmacology is all a waste of time. Hardly, no, wrong. It's important to say, yes, there is value there. But is that the only way to do it? So in this, I would say, is the ask of all of you that we approach global health with humility, with intellectual curiosity. I'll guarantee if you start with those 2 points, you will find joy. If you go in with I know the answers because, I came from Northwestern. It's a big university, or the University of Minnesota. You will miss the point about the joy of global health. Andrew Muvende is a journalist from Uganda, and he's been talking about this for a long time. There are others, by the way, who've asked this question. Aid for Africa, no thanks. And his point is that all the years of aid that Africa has gotten, various countries in Africa have gotten, has created dependency structures, that it has squashed innovation. It has led people to be less resilient of the work. So when we do our engagements, we need to ask the questions, are we just doing it from a largesse? And in that, are we creating more dependency structures? So you folks heard that USAID is eliminated, right? Many countries' health systems suffered. I'm not saying we should have done it the way we did, but I'm going to ask the question, why did we get so dependent on USAID? Why do countries get so dependent? So in your work that you do, whether you like it or not, you would come from a place of economic superiority, right? And when you come from a place of economic superiority, please keep in mind that that's not a good thing. It tends to breed arrogance. It tends to breed a sense that, look, I'm the one bringing in stuff. There's a brilliant essay from gentleman from Ghana, a physician from Ghana, just after COVID. He said, "Oh yes, I'll drop all I'm doing to come to the airport to pick you up. Because, I'm not a busy surgeon." "Oh, but you're coming from the US, so I'll drop everything. My patients who are waiting, an emergency surgery. I'll come to the airport to pick you up." So try to understand where you're coming from in this conversation too, okay? More often than not, we talk about help, and help is the dominant framework of conversation in global health. The challenge we have is that the premise of help is sometimes a challenge. Folks have probably heard the path to hell is paved with this good intentions, right? A friend of ours, Noel knows her, Judy Lasker, wrote a book called Hoping to Help. Interestingly, majority of times she actually caused more problems. So keep that in mind as we talk about the engagement in global health, right? This was a statement, this is an old statement by an Australian, I believe in the 1980s, and this has been dear to my heart. "If you have come here to help me, you're wasting your time, but if you come because your liberation is bound with mine, let us work together." I would also say that this statement asks the question, what is your motivation? Where are you coming from? What baggage do you bring? Right? This part of the program, I would strongly recommend you stay awake. Otherwise, you can fall asleep. Guys ready? Okay. And I'm going to borrow this from that Katrina story. I got really interested in Katrina because I used to live there, right? And the thing that bothered me a lot is how much outside folks were influencing or trying to influence what we were doing. So I started looking at some of the literature, and there's this a sociologist by name Quarantelli who was at the University of Delaware. And this is called the Quarantelli paradigm that's been dear to my heart, and I've actually taken this as a framework to understand what work happens in global health. So I'm going to start this with a little bit of a story here, okay? How many of you are here from a small rural town? What town?
It's called Lufkin, in Texas.
Lufkin, Texas. Okay. Is that South Texas?
Southeast Texas.
Southeast Texas, near Houston.
Yeah.
Okay. So let's assume that in Lufkin, Texas, you have a hospital, and that hospital's primary job is to deliver healthcare. You all with me, right? So in Lufkin, Texas, the primary job of that particular place is to deliver healthcare. That's an established organization. And this is Texas, so there's bound to be football. So there's a football game going on in the local high school. By the way, that's the second religion, or maybe the first religion in most of Texas, is football. And in that game, there is a strong tackle that occurs, and one of the wide receivers has a fracture of his femur. That can happen in football. I've seen it happen in football. And somebody calls 911, and the police show up, and the fire department show up. So by definition, the police's work is not to deliver healthcare, right? Right? I hope not. But they're there as an extending organization. So it's understood that there is an old relationship that exists within the healthcare system and that community, that when a 911 call comes in, a few people respond, the cops and the fire department. So that is what you would call an extending organization. An extending organization's primary purpose is not that primary thing, but they're there to help. All right? So in Lufkin, Texas, I think I know where Lufkin is, a huge hurricane shows up near the coast. It starts blasting in. And that is this fabulous red line that I've drawn. That's a disaster, okay? Disaster, by definition, is an event that overwhelms the capacity of the local community. So in Lufkin, if there is a car accident, it's not a disaster. because there is capacity within Lufkin to take care of it. I hope there is capacity to take care of it. But when a disaster occurs, in this case a natural disaster occurs, the capacity of that community to handle that is not being met. So now we have other organizations that come in. The governor of the great state of Texas asked for help. I hope he asked for help. And then the National Guard shows up. Or DMAT units. Have folks heard about a DMAT unit? It's like a MASH unit. It's like the National Guard who train together, but they're a healthcare unit. They show up. And that's an expanding organization. And their job is to deliver healthcare to help that small hospital in Lufkin to take care of all the casualty that has occurred there. Because the elected representatives of that community have asked for help. And what's your name again? Alex. So Alex's friends from Northwestern hear about this calamity and they say, we need to go and help. They are these emergent groups. This is a framework in disasters. I'm going to make a case, so bear with me. This is sometimes a framework that is used in global health. That we assume that the capacity of the local setup is not adequate to take care of the problem, and in many situations that's true. The HIV burden in many of the communities in Sub-Saharan Africa as a region, not a single country, is not enough. There are newer diseases coming. There's challenges of malnutrition, the challenges of drought, etc., etc., etc. So yes, then we want new relationships to occur. So that disaster is not a single hurricane, single event. It is probably a series of events that have led to the local community not being able to take care of it, right? So when people ask me, how do I participate in global health? My simple answer is, you move from being an emergent group to an expanding organization. That's a quick answer. In other words, you be part of something different than a random weekend trip or a quick mission trip. You go in with the idea that there is a plan and there are specific skills, if you do have the specific skills, that you contribute for the betterment of the community. So remember the story I told you about Katrina, where I lived, where the community kicked out? That was because more often than not, we have too many people in this category and they cause more problems. It's well known in disaster sociology that volunteer groups almost always cause more problems. They don't really alleviate the situation locally. Very rarely are there instances where it actually makes a difference. So if you do, and you have the capacity and the training and the skills and the resources, move to this. Questions? That is my summary of global health. Now, this is based on a premise that we recognize there is a disaster. And I would not necessarily call it a disaster. I would say the capacity of the local community to take care of it is not good. In a majority of situations I've seen, a lot of the capacity in the local community is really good. It probably needs to be organized better. Yeah, it needs to be organized better here in the US. Healthcare delivery here in the US is horrible. We need to organize here better than another country, right? I'm going to transition my slides in a minute, but when I do that, any questions to what we have talked about till now? The challenge we have in rural health in the US is 70% of the health professional shortage area, it's a specific designation here in the US, is in rural areas. There's a significant shortage of healthcare professionals all over the country, but specifically in rural areas. And all over the country in specific fields, we are oversaturated with specialists. The US is. We say generally the best care delivery model in any part of the world is when you have 70% of the healthcare professionals, in this case, if I say physicians, should be primary care, 30% should be specialist. In the US, we are about 30 to 40% primary care and 60% specialist, and the number is getting worse. My university is the top university in the country sending people to primary care, and we MD graduates, not DO graduates. And our number is a brilliant but horrible 17%. So we are not doing a good job in the distribution of physicians, both from a professional viewpoint and a geography viewpoint. And that's important to keep in mind. So I'm going to, forgive me, transition to a really brief presentation of what we have done in Minnesota, because Noel asked me, sometimes we get frustrated because the challenges we see are not easy to answer. How do I suddenly provide another 3,000 extra primary care physicians in rural Minnesota? I can't, right? But how do you address the problem? So this is a brief presentation on that. And early on, I had an encounter with the CEO of a nice hospital called CentraCare. I've really had the pleasure of interacting with him a lot. And I loved what he said. It's not enough to admire a problem. We need to engage with it. And I think the engagement part is critical because sometimes we get caught up in the idea that I can't solve it, so I'll revert back to what I know, as opposed to saying, I can't solve it, but I need to be present with others in addressing the issue. So what did we do in Minnesota? We did a strategic approach, and I had the privilege of leading a really fascinating team. First was to understand a problem. I actually got a grad assistant who did some brilliant work, who's now come back to do a primary care residency with us, to analyze the challenges of rural Minnesota. What are the numbers? What are the areas that are shortage? Where are the hospitals? What do they do? What are they doing for recruitment? What are the alternative models of care? And then this was a 7-year journey. We started by engaging stakeholders, not from an answer of, I know I can produce 3,000 new docs. No, I cannot. What do I do to collaborate with others? And collaborating here included local communities, a lot of town hall meetings, health systems, which, by the way, is very difficult to engage because they don't like each other. One health system is a sworn enemy of another. So sometimes I say, I might be the neutral Switzerland here because I'm not part of a health system. So convening groups together to talk to each other, talk to us, and government bodies. For the past 6 years, I've been meeting with the Minnesota Department of Health roughly once every 6 weeks. And I've learned so much from them. I thought I knew all the answers, right? But I learned so much from them. So then we started looking at what are the existing strengths within the university, within the state. How much can we really get from the federal government? Not much. There's a lot of dysfunction going on in Washington, D.C. So this has led to us doing some interesting implementation. We opened a new rural medical school in a place called St. Cloud, Minnesota. It is the first new medical school in Minnesota in the last 50 years. All our students come from rural areas. And we just matriculated our first group last August. I co-chair the governance of this school, and it's been so much fun seeing that. We started opening in the US. Have you folks heard about GME? GME stands for Graduate Medical Education, which is what you do after medical school, residency training, right? So we got some federal grants to get started. So we have 3 new rural training programs in Wilmer, Grand Rapids, and Staples, Minnesota. 1 a year. So it feels like we have next one in the pipeline, next one in the pipeline. Wilmer was first. We just recruited a second batch. Grand Rapids, we are recruiting the first batch this year, and Staples will be next year. And we have 2 more in the pipeline. So it's almost like we've discovered a formula. So let's feed the formula and see what happens. And it's been fabulous because we have rural communities who are like, yes, we want to participate with you. Completely different health system. Every one of these health systems are different. but they want to be part of this, right? We've been collaborating quite vigorously with the Minnesota Department of Health. And we set up an expert team that one of my mentees is heading. She's now the national board chair of the Rural Medical Training Collaborative, which is a consultative group. And we will do the consultation pretty much free to come to any part of the country to help you understand what do you do for rural training? What are the problems? What are the challenges? What are the regulations? And how do you get past all of that? And we are, that part has been really good. And the part that has been really interesting is we started a high-fidelity rural obstetric simulation training program. One of the challenges in rural areas is that obstetric care is dropping and hospitals are closing their labor decks and eventually hospitals close. And these high-fidelity simulation models are expensive. They're about $250,000 each. But when you operate, and I've done this, it feels like real skin. It feels like real uterus, right? So we can do this to train rural docs who were practicing obstetric but need a little more training, a little more ongoing training. So we take this on the road. We go to small rural hospitals, critical access hospitals, 25 beds or low, in various parts of northeast, northwest Minnesota, almost Canada, and we say that with a lot of pride, to do training in rural obstetrics. And that's been a fun part to see that now we hope the labor decks don't close. And the narrative we have of rural obstetrics being a problem, we're changing, right? We just got some funds to get a family medicine obstetric training program. We're going to place this in our rural setup, and I'm excited about that. What lessons have I learned? One, it does take time. This is a 7-year journey. And the journey is not over yet. We have built a really good team. I'm really happy to say I have one of my mentees, I say she's my retirement plan, so I can just give my portfolio to her and work out, right? But creating those organizational structures is critical. Now, this is an important story because quite often we get frustrated that we cannot answer the questions that are there because it's not easy to answer complex questions. And then we revert back to what we know. It is important to keep engaging in this. I was planning on showing something else, but it is the top of the hour, so I'm going to shut up and open this up for questions. Thank you.
So we're recording this. So if you wouldn't mind any questions, I will sort of dash over to you somewhat awkwardly with the microphone so that we can pick up your question.
But the mention of that rural programs is not a way of bragging. It's to say that it takes time. It takes a lot of time sometimes. But looking back, 7 years is not a lot of time for creating structures, right? So that's something to keep in mind.
I've got a quick question to launch us. I was just curious, these are really interesting programs you've built for training rural health and for having that training happen in rural areas. But are all the systemic incentives for those doctors to go into more lucrative specialties, wouldn't they still be there? So how do you also incentivize them once they've done this training to stay there?
Yeah.
Right? Which is a question in global health more broadly. How
Right.
do you incentivize global South doctors and health workers
Yeah.
to stay there?
Yes, some of the data we have is that the chances of a trainee staying in a rural area is higher if you train them in a rural area. There's actually really good data behind this. Interestingly, people who are practicing in rural areas get paid more than when they practice in urban areas. Some of my residents graduating and going to rural practices are getting paid more than I am being paid, which is brilliant. I think that's great. The part that is important to keep in mind is it needs a lot of mentoring and nurturing about what it is to practice in a rural area. The economic incentives that you talked about is a very critical point because specialists tend to get more. The discrepancy between primary care and specialty is pretty high in the US, one of the highest in the world, by the way. That needs to come down. I don't know if that's going to happen anytime soon because we have powerful forces that fight any reduction in physician salaries. So that's going to be a challenge. But we have seen that when you create the milieu, they do end up going rural. So.
Further questions or comments?
Whenever you were making these programs and coming up with these ideas, were there any other like rural health interventions or organizations that you looked to, or that just more generally before this that gave you hope?
Good question. So one is there is a model called a rural training track, which is an innovative model where you train people for a year in an urban area, but years 2 and 3, if it's a 3-year program, in a rural milieu. And there were some models outside the state of Minnesota that I really liked. One in rural Washington and one in rural Oregon. And I'm like, there is some model there that we can do. The medical school part, there are places that have done medical schools in rural areas. Kansas has done that. There are many others who have done that. But again, this is the lesson from global health. Don't try to replicate. Get some ideas, but don't say this is exactly how you're going to do. Because each health system, each community is different. So when, one of our pet conversations when Noel and I meet is that everybody wants to scale up. I'm like, scaling up is not always possible. You listen to some of those lessons. You take some lessons from that, but don't expect that that's exactly how it's going to be in another place. The third part for me, I think, is a very critical part, is that the health system, it's a private health system. They were interested. That helped a lot. So we didn't have to sort of fight through that part, right? So, yeah. And now, I told you there are 2 in the pipeline. They are seeing the success of rural training programs, and they're like, we want to be part of this too. So, yeah.
As always, riveting. My question is actually, have you actually talked about what is going on in Minnesota more broadly? Have there been others that have expressed an interest? And the reason I'm asking about that is I know that there was a physician group in California that was looking at like how to reduce maternal mortality by measuring blood output after deliveries to see when they can actually identify that hemorrhage is occurring and when to intervene. And so I'm just curious because that was when they were trying to spread and a lot of physicians were like, nope. So I'm curious, like, how well known is the work that you guys are doing in Minnesota, and what has that engagement outside the state been, if at all?
I want to say more to come, but I'm going to have to share with you some news. We got a donor who gave us money, and we'll take more. Anybody here has money to do some stories. The narrative of rural medicine is bad, right? Then people say they're going to work for Indian Health Service, or if they're going to work in frontier area, like, oh my God, poor you. What we miss is there is a lot of vibrancy in communities. So we are going to be doing some stories. We started some, I have a faculty member who's the voice of Minnesota Public Radio. He's an Emmy Award-winning producer. So we are going to do movie shorts about rural health. And that's going to be one of our major things of doing. We are creating a center called Prime for that. Last week, we held a conference in Duluth, Minnesota, which is way up north in Minnesota. The Rural Medical Training Collaborative Conference was held there, and we got people from various parts of the country, and we talked about what we have done, and not from, hey, this is the model, but these are the lessons we learned, what are the challenges, those kinds of things. I think we need to keep doing that. The other part that is critical is, and you brought up the point about obstetric hemorrhage, what we want to make sure is the narratives we talk from a structural viewpoint become the backbone on which those stories are planted, right? So in other words, if you have the classic story of obstetric hemorrhage is a good one, but if the labor deck is closed, that story doesn't matter anymore, right? So why don't we create the structures where chronic disease management, mental health management, and looking at wellness, which I'm hoping we'll do more. We're going to be convening all the health systems in Minnesota to talk about primary care. I don't know how it's going to go. But start the conversation. What else can we be doing? Is there a better model? So, yeah. And I don't know if there is, but we have to be looking for that. Yeah. Yes, sir.
Any of your neighboring states, Iowa, the Dakotas, Nebraska, Wisconsin, show any interest in the Minnesota program?
So we do get a lot of students from neighboring states, including the Chicagoland area, who come to Minnesota to train. Wisconsin has done an interesting model for rural GME. The state has funded 100 slots for rural GME, and I'm actually using that as a, how shall I put it, shaming tactic to say, you want Wisconsin to beat us? We should be funding more rural GME from the state, and I'm getting a little traction from the state legislature to get some, state, because most of GME funding is from the feds, so maybe some state funding too. So yeah. So yes, there are some other models. Yeah.
Maybe on that hopeful note, we can thank our speaker and wrap up for the day. So thank you very much.
Thank you.
And thanks everyone for being here. And if there are still empanadas, bring them to your friends.
And I'll be here for a few more minutes if you want to have any other questions.